wouldn't think she's morbidly obese, but she came to me and she had met another RE and had one consult. And she told him, I haven't had a period in 2 months. I think he did an ultrasound. He didn't see much activity, and he told her she would need donor egg. And then she told that to a friend. A friend sent her to me, and I put on my detective cap and said, this may sound like I'm stereotyping, but it doesn't really make much sense to me that you would be Latina and at age 40 to suddenly need a donor egg. Why don't we do some testing? And so I sent her for an A1C and a few other glucose tests. And it came back that she was in a diabetic state. So then we worked on managing her blood sugar and her diet. She did the seed program and really followed it to the letter. I made a referral to a different RE. She did one insemination. It didn't work. She did a second insemination and got boy-girl twins.
Oh, amazing.
I mean, that's what can happen when women take their power back.
Right.
Right. And we see that all the time.
Right.
I'm glad we talked about PCOS, but could you say a little bit more? Because we talk so much about a diminished reserve and a advanced maternal age. Those are, and endometriosis. I would say those are our three. That's our primary patient, but the PCOers are going to be approaching, or are you working with PCO patients?
I am working with PCOS patients, but oftentimes women are misdiagnosed as having PCOS.
And it's endo?
No,
Oh, okay.
Sometimes it's oftentimes it's hypothalamic amenorrhea. And so when you look at, I asked them, well, how were you diagnosed with PCOS? So one of the mainstays of the definition of PCOS is you have to not ovulate. So women who ovulate, you're not PCOS. And oftentimes when I ask them, they'll say, well, I did an ultrasound and it showed that I had a lot of follicles. Well, it could just be a young woman with healthy ovaries. So she gets a period every month, then you're not PCOS. In PCOS, you are someone who doesn't ovulate. You also don't recreate a dominant follicle because all the follicles are competing with each other, and you don't have a lead dominant and you don't ovulate. The minute you have a lead dominant and you ovulate, that can't really be PCOS. You could be a variant or you could have something else going on, but it's not PCOS. The other times are when you look for, do you have an elevated free testosterone or a 17-hydroxyprogesterone? And they don't. So if they have no elevated androgen or a male hormone blood level, you can't really be PCOS. So I find that oftentimes people are just, it's a real throw catch-all. As soon as someone says their cycles are a little irregular, people are told they have PCOS. And so then they kind of go into a spiral. So we really try to figure out what's the correct diagnosis. I had a young girl, she just went to college and she stopped getting her periods. And she had seen 4 different GYNs. And one scared her parents quite severely by telling her she had the most severe form of PCOS she'd ever seen. This just happened. And so when I said, well, just send me the records, let me just take a look at the labs and figure out how she was diagnosed. Free testosterone is normal. Her estrogen is low. Her FSH and LH are both really low. They're under 5. They're under 3. Her prolactin was normal. Her thyroid is normal. Her ultrasound, and what was really hard is she was virginal and she had a transvaginal ultrasound, which apparently was very traumatic for her, which really wasn't necessary, but she had it done. And, the parents really felt at a loss because they felt like they just wanted to help their daughter. But, they were listening to their doctors. So when I looked at the numbers, I said, well, I don't see any evidence of PCOS, but I do suspect she could be hypothalamic. Her thyroid, prolactin are normal. Her FSH and LH are really low. Her lining is paper thin. In PCOS, your lining is really thick. There's no pattern to it because you're hyperestrogenic. And so this doesn't make sense. But let's get you to a medical endocrinologist because I'm just your neighbor. I don't want to be the tiebreaker. And the medical endocrinologist also confirmed, yes, let's just do an imaging of the pituitary, make sure there's not a pituitary adenoma, which is benign. And he also diagnosed her with hypothalamic amenorrhea, which was exactly my diagnosis, which is exactly the opposite of PCOS, and the treatment is different.
Right.
And so that was really eye-opening because for the patients, they were my neighbors, and they had a hard time because they had 4 prominent gynecologists in Los Angeles tell them all the same thing. And
that she was PCO.
Right. And one of them told her it was like the most severe form of PCOS she'd ever seen. Mm-hmm. And what was amazing is one of the 4 that same day, without any, like, there was no contact with this person, sent a message through the portal to her daughter saying, my partner reviewed the labs, and actually, the partner actually sent the portal message saying, I reviewed the labs and I disagree with my partner. I think you're hypothalamic amenorrhea. And so having that validate on top of the medical endocrinologist and then me, the curbside doctor, as her neighbor, it was really, helpful. But this college student would have gone down a completely different road. They were going to put her on metformin. They were going to put her on, birth control pills and not address the underlying issue.
Right. So hypothalamic ovulatory dysfunction or amenorrhea. What is the current treatment for that?
So you have to address what's the underlying reason why they had that hypothalamic amenorrhea. It could be extremes of BMI.
Could be trauma. Remember, we had that one case. Or
any stressor, right? Mm-hmm. So it's, some type of stress. So even if they feel no sense of stress, so the medical endocrinologist is actually doing a 24-hour cortisol, and to just assess that even though you don't feel stressed, maybe you are stressed. So
but the hypothalamus is perceiving that you are.
Right.
Mm-hmm. Right. We had that one case that walked in on her brother's murder, or he had accidentally killed himself, remember? Trauma. Mm-hmm. And that just tipped the dominoes over on a whole lot of other stuff. And to not be menstruating brought her into your care, then to my care. Yeah. Helping the hypothalamus come back on board is a nuance.
It's very nuanced, because also when these are the women where they will not respond to Clomid. So whenever the people have hypothalamic amenorrhea, if they're misdiagnosed with PCOS, the first line is gynecologists will give them Clomid, and they don't respond because their pituitary and hypothalamus aren't functioning. What Clomid does is it tricks your brain into thinking that your ovaries aren't functioning and the pituitary has to send out more FSH. But if you have that access isn't working properly, the Clomid, you won't respond. And so then these women go into a panic, and really the treatment for them is to do a very, very low dose of of Menopur, which is both FSH and LH, because they're missing those 2 hormones. So it's not Clomid. Clomid will not work for someone who's truly hypothalamic.
Right. See, all these things, it's so cool. As time goes on, we get to find out, which is exactly why we know that, or we can say that when the fertility is hindered, it's a biomarker, or, like Dr. Turek and the male fertility, using fertility as a biomarker for poor health. Right. So,
well, I definitely will tell people that when a woman's menstrual cycle is irregular, it tells us something's off, and we can uncover whether the thyroid is off or there's some other medical condition going on. For men, it's true with the semen analysis. When the semen analysis is abnormal, I've uncovered hypertension, high cholesterol, cardiac issues. And so it is a biomarker.
Yeah, right. And, if the reproductive system isn't necessary, it's going to be shut off when these other systems need to be put into high performance for whatever reason, stress in particular. So there's so much exciting stuff coming around the corner, right, with respect to fertility. And I'm just so curious. I'd love to pick your brain. I mentioned some of it, the AI and this prospect of women scanning themselves, like in the future, where not only will they go to MDR for their meds, but they will get their own transvaginal wand, and they will
That'll be very, very limber, right?
Yeah, they're going to somehow know how to navigate the ultrasound wand to count their follicles, and the printout will be transmitted to their RE, and the RE will then prescribe the meds. It's really separating the doctor and the patient. The look on your face is so validating, right? So the acupuncturists are saying, but what about the human touch? And the MDs are like, this is like and I really can't argue, like technology is changing so fast, and some women might want to do it like this, and it can drive the costs down. There's a lot of arguments for it, but there was a time where a 5-day transfer seemed like, how could we do that? We just we need to put them in at day 3. The science just keeps changing. So the look on your face tells me you're not going to be, I already know, the concierge care that you provide, where you just will not budge on that. You want to be there for your patients. I know that makes a difference.
I do think it makes a difference. I think that having, whenever we're not technicians and just you can't plug and play, and there's no cookbook for this. And so when we see things standardized, it works for a lot of egg donors. It doesn't work for women in their 40s or late 30s or women who have a diminished ovarian reserve. It just doesn't work.
Right. It works for people who are going to freeze eggs potentially.
Not really. So for egg freezing, it's even more nuanced, because with egg freezing, that's where it's really critical with the egg quality. I think egg freezing is much more challenging than embryos. And people think egg freezing is a walk in the park.